How's it going, guys? We have a past level question for endocrine, physio, step 1, internal medicine, 2CK, 41-year-old man. Health maintenance examination, BMI 23. His blood pressure 100 over 65, which is slightly lowish. Laboratory studies show sodium normal 140, should be 135 to 145. Potassium elevated 6, should be 3.5 to 5. Bicarb slightly at the lowest end of normal, okay, so 22 to 28. Question wants to know which of the following most likely we see in this patient. Let's just hop to the answer here. Choice A, alkalosis, wrong fucking answer. So clearly our bicarbonate is low, and so we're going to have a metabolic acidosis or very close to it. We don't have the pH here. I didn't give us the CO2. Now, sometimes USMLE will give you a bicarbonate either on the cusp, basically on the cusp, and you can still have an acidosis as we might expect in this case, or at the upper end, 28, you could still have an alkalosis. Right? I'm just letting you know that the margins can be slightly blurred. I've seen that in USMLE questions before. So if anything, we could have a metabolic acidosis in this case, and you could conjecture and say, well, what if we had a chronic respiratory alkalosis where bicarbonate has gone down to compensate? It's not impossible. There's better answers here. Okay, it wouldn't make sense in terms of why our potassium would be elevated, even if we wanted to conjecture. Wrong fucking answer. Choice B, decreased secretion of renin, wrong fucking answer. So our diagnosis here is Addison disease. All right, so we've got elevated potassium. We have bicarbonate that's low-ish. Doesn't have to be 20. Doesn't have to be out of the normal range. I'm telling you what shows up in NMEs. Now, some of you are going to be very confused. You say, I don't get it, though. Shouldn't sodium be low in Addison disease? I said 135 to 145. Okay, well, if you've gone through my PDFs and if you've watched some of my prior YouTube clips, I would say on USMLE about a third of questions where there's aldosterone derangement, sodium will be within the normal range. That confuses students, okay? But it's a factoid you need to know. Yes, if our aldosterone is low, as with Addison disease or Waterhouse-Friderichsen as an example, then we would classically expect low sodium, high potassium, low bicarbonate, low pH. But as I just harped on, if about a third of the time, you can expect your sodium to be in the normal range. So our secretion of renin would be increased to compensate in the setting of primary adrenal insufficiency because we're going to want RAS to be jacked up. We want renin to be high. There's going to be decreased renal perfusion. So if our aldosterone is low, it means we have decreased fluid reabsorption in the cortical collecting duct of the kidney. Our volume status is low. It explains our low blood pressure. Renal perfusion is low. Renin goes up to compensate. And we want that because more renin, more angiotensin II, more aldosterone. Wrong fucking answer. Choice C, increased ACTH. Correct answer. Okay, well, that's what we'd have in Addison disease here. So primary adrenal insufficiency, our aldosterone and our cortisol are both low. Both are low. So these electrolytes reflect the low aldosterone. The low blood pressure is a result of both low aldosterone and low cortisol. So cortisol is necessary for maintaining basal blood pressure. It helps increase expression of alpha-1 receptors on arterioles peripherally, which allows norepinephrine and epinephrine to do their job and bind so that we get vasoconstriction. So in the setting of low cortisol, decreased negative feedback at the hypothalamus anterior pituitary, and that's going to lead to increased ACTH. Okay, it also leads to hyperpigmentation because precursor ACTH is POMC, which is also the precursor to alpha MSH. So let's just hop to the other answers here. Choice D, kaliuresis, wrong fucking answer. Sophisticated way of saying increased potassium micturition, increased potassium in the urine. So clearly if our aldosterone is low in the setting of Addison disease, then we're going to have decreased secretion of potassium into the urine, which is why our potassium's high. Wrong fucking answer. Choice C, respiratory alkalosis, wrong fucking answer. So this is going to be a difficult answer choice for some of you, actually. Some of you are going to be very heated and emotional right now, okay? So if we have a metabolic acidosis in the setting of Addison disease, we want to think about what are we going to do to our CO2 to compensate. We're going to want to blow it off, right? Because CO2 is acidic. So we would have metabolic acidosis with respiratory compensation. Yes, we would blow off CO2. So normal CO2 is 33 to 44 millimeters of mercury for PCO2. But so we could expect a suppressed, slightly reduced PCO2. But we don't call that alkalosis because if you apply the terminology, alkalosis or acidosis to a metabolic or respiratory disturbance, it implies that there's a pathology. So we don't have respiratory alkalosis here. The fact that our CO2 would be low because we're blowing it off, that's not respiratory alkalosis. This is a metabolic acidosis with respiratory compensation. If we have, for instance, a metabolic acidosis with respiratory alkalosis, a mixed pathology, that's salicylates. That's aspirin. It's a long fucking discussion. Wrong fucking answer. You know the deal. To make more content, I feel like my stuff, subscribe my channel. Appreciate your time. That's it.